resources, and that's largely due to all of the faculty, the 7 faculty members that gave 90-minute presentations. I highly recommend that you get the MP3 recordings. I'll talk about those in a minute. And then the 2017 symposium was 2 full days instead of a day and a half, and that was largely because we had the most case presentations and the best case presentations that we've ever had. I was so proud of everybody that presented. And then the most exciting thing for me was that Friday, second day of the Advanced, and Saturday the Symposium, we got physical copies of The Resonance Effect, the book that tells the story of how FSM was developed. It's written for patients. It is very readable. It's a, Jim Oshman described it as a can't-put-it-down page-turner of a book. He said it's fascinating, funny, inspired, exciting, and altogether delightful. The reviews have been great. It is available on Amazon for release on April 24th. We have copies here at the office, and we're close enough to the release date that we can sell those copies. If you call the office, we can send you one. I think it's $17, $16.95. So it's been really fun. The good reviews are even better, but this book is intended for your patients to help create the idea in the collective consciousness that frequencies can change tissue. It tells the story of how we turned a list of frequencies into the protocols that you use every day, and it tells a story that your patients will appreciate. It has visceral protocols in it that I don't have enough literature or published papers to publish a textbook about the visceral protocols, but we have protocols in Chapter 9 for irritable bowel and Crohn's and asthma, and it's just a fun book. So I'm hoping that practitioners will buy multiple copies and sell them or give them away to their patients, have a lending library, or sell them to their patients as a way to explain how FSM was developed that you use as you use it. And I'm really hoping that we can create a 100th monkey effect and create in the collective consciousness the idea that specific frequencies can and do change tissue and make it healthier and more pain-free. So I'm just really excited to have this book out. So that's that. I got a phone call from a practitioner today, and hi, Deepika. I got a phone call from a practitioner today who said, he said, oh my God, I'm halfway through the book and I thought I knew the story of FSM and I thought I knew you, but I don't. And after reading half the book, I now understand where we come from. So I'll just leave that as a teaser for you and move on. Charlie Braverman, how exciting. Yay, I'd love to see your names on the list. So about 2008 or 2009, it became apparent that the frequencies for shingles were not working the way they usually did. So it actually might have been 2010 or 11. We thought, 2009, 10, we thought that the machines were maybe, the frequencies were off. Turns out that wasn't it. We went up to Seattle and put them all on scopes, and the frequencies were completely perfectly accurate. So it wasn't the machines. It took a year or two more to figure out that it seemed likely that the virus had mutated. I think it's because of the shingles vaccine, but that's another conversation. So we I didn't have a fix for it until I got shingles. I think it was in January or February, and I was running 230 and 430 and couldn't get it done. It was in one of the lumbar nerve roots, and it was itching and painful, and 230 and 430 wasn't cutting it after maybe 6 hours of treatment. So I called Dr. George, as I do, and he said, try this. So the modified frequency was 236 and 435, and that took care of it in about 2 hours. It took one treatment at 236 and 435. I'd already run 4, maybe 6 hours of 230 and 430, and it kept it at bay, kept it from being horrible, but it was still not getting the job done. 236 and 435 took it down in 2 hours, and it was a one visit fix. So it works faster and adds to the effect of 230 and 430. I would still run 236 and 435. I would still run 230 and 430 for like an hour or two, and then add 236 and 435 to that. So I'm not ready to replace 230 and 430, but I'd add to it. So maybe split it. If you're going to run a 2-hour treatment, do an hour at 230 and 430 and an hour at 236 and 435. Deepika raised a hand. Do you have a question on your screen? Can you see Deepika's question? The bulk of this webinar is going to be a symposium review of just 2 of the case reports, just to give you an idea of what we were experiencing. And this one becomes relevant because my Achilles tendonitis is flared up and has been for about 8 or 9 months, and running the normal tendinopathy thing of 124 and 191 hasn't fixed it. It turns out that I was on Avalox for almost 2 years for a chronic sinus infection from my bone infection in my jaw. And Avalox turns out to be one of those antibiotics that causes tendinopathies. So my Achilles tendinopathy is related to the use of this antibiotic. So this last 2 weeks since we got back from Las Vegas, I've been using Dr. Musnick's presentation in physical therapy. So Jody Adams at New Heights has been treating me, and we used what's in this presentation, and I'm off a cane for the first time in 4 months. So that was pretty exciting. Robert Teeter, is there sound yet? So we're having that same problem. See if you can get back to Robert. Okay, so this is these are slides from David Musnick's presentation. These advanced presentations and symposium presentations will be available on the website as part of the advanced compendium, I'd say within the next week or so. So a normal tendon has highly organized fibril matrix consisting of type 1 collagen and minor collagens, proteoglycans, and glycoproteins. It's not just a cable, it's a complex structure. The tendon matrix is maintained by tenocytes, which are fibroblast-like cells, and there is a continuous process of matrix remodeling in normal tendons. So you normally wear and tear on a tendon during the day. You go running, gets a little sore, it repairs itself overnight, and it's healthy the next day. So what can happen to a tendon? It can stay healthy. There you go. It can become inflamed or create tendinitis. It is a partial or a full thickness. There can be a partial or a full thickness tear. There can be thinning when the tendon doesn't repair itself on a regular daily basis. And then there's what I have, and what lots of other people have, is a tendinopathy or tendinosis, where the tendon becomes painful and sensitized and degenerated. And as part of that process, the tendon becomes inflamed. So these are all the things that can happen to a tendon. Oh, yay, Robert found it. Okay, welcome. Multiple tendons. If multiple tendons are involved, think of an autoimmune issue or a regional issue. So if you've got a tendinopathy in the shoulder, and there's more than one tendon in the shoulder, that becomes a regional issue. If you have tendinopathies in the shoulder, the hip, and the knee, and the Achilles, then, and it becomes chronic, if there's tendinosis in 2 or more body regions, you can have a number of reasons for that. Low testosterone in both males or females. So menopausal women don't make adequate testosterone, and andropausal males. So you'll see tennis elbow and Achilles and hip tendinopathies in 50-year-old women and 40 to 65-year-old men. And that can be when it's regional or in 2 or more body parts. It can be related to low testosterone, low DHEA, which is related to low cortisol or low adrenal function. So if somebody is adrenally exhausted, so your chronic fatigue patients and your autoimmune patients can have low cortisol, low DHEA, and when you don't have enough cortisol to keep the inflammation down, the tendon becomes inflamed and because of lack of cortisol, and then it doesn't repair itself. All tissue repair in an adult is mediated by growth hormone. So if your growth hormone is reduced, you won't repair your tendons. So 38-year-old male who has multiple tendinopathies or tendinoses. Anyway, it's worthwhile to check IGF-1, especially if that patient has had an auto accident in the previous 2 or 3 years. So you can have a patient who has 40 and 10 fibro who during that auto accident had a head injury that compromised the pituitary, that compromised growth hormone releasing hormone, and that patient doesn't have growth hormone. Now there's going to be other symptoms of low growth hormone, especially in a male, but even females. Fatigue, sleep disturbance, and chronic muscle pain are pretty common. If pain in the SI joint plus the tendon pain, the tendon and tendinosis, it may be an autoimmune condition. So if that is the case, then treating with functional medicine and FSM is the most appropriate. So turning around autoimmune conditions is not totally easy, but it's doable. Fix the gut, clean up the diet, use FSM to repair the gut, quiet down the immune system, hope for the best. So multiple tendons, and once again, this is David Musnick's presentation. I highly recommend it to you. So blood flow to the tendon, they're not well vascularized, right? The enthesis is where the tendon attaches to the periosteum. So the blood flow to the tendon and to the periosteum at the tendon attachment is not that great, right? If you remember back to dissection, there wasn't a big blood supply to tendons. Tissues with less blood flow heal slower and are flared up by factors that decrease the blood flow. So restrictions in peripheral circulation, elevated stress levels, so vasoconstriction, it's an issue that can impair the tendon repair when the blood supply is restricted. So there can be neuronal sprouting in the blood vessels and the tendons, and those become sensitized. So Jody and I have been treating my left Achilles for, I don't know, 6 months. I was treating it for 6 months before that. I finally gave up and went to see her, and we hadn't made a whole lot of progress. We got back from Las Vegas, and I went in with this presentation, and we started treating torn and broken in the blood vessel and the capillaries. 162 is the capillaries. Inflammation, pain sensitization. 321 didn't do much, but the blood vessels are innervated. So when the neurons are vascularized, so the blood vessels and the nerves go together. So when the nerves get inflamed because of the inflammation at the tendon and the periosteum, when they become inflamed, the nerves do what's called sprouting. It's kind of like trimming your roses, and you cut one and 4 show up. That's what happens to the nerves, and the nerves bring blood vessels with them. So when we got back from Las Vegas, we treated inflammation and pain reaction in the blood supply, the nerves, 62, 396, and the capillaries. And I was off the cane at the end of the session. Torn and broken, I can't say we tried that in the blood vessels or the capillaries, but it's on the list because there's still thickening at the tendon. Periosteum, if you think about where tendons reside, where tendons attach, it attaches muscle to bone, and the regional pain or the pain at the tendon come from the periosteum attachment, and they call it an enthesis for reasons I don't understand. But the tendon attaches to the periosteum, and if you can think of the tendon as pulling on or creating micro tears in the periosteum, and you think of the periosteum as very well innervated, that will give you an idea about the pain generation at the periosteum. So on physical exam, the periosteum patients will be tender at the bony attachment site of the tendon. So you'll end up treating the tendon and the periosteum. And here's the other trick, and the cord area that's processing sensation from that tendon. So you treat the periosteum with 40 and 783 inflammation in the periosteum, but this I didn't realize. The chronic pain from the tendon and the periosteum leads to central sensitization. So you treat with 40 and 10, obviously with the second machine, 40 and 10 for 5 minutes. I run 40 and 10 the whole time I was treating. Jody and I haven't done that with my Achilles yet. 20 and 10 for pain sensitization. And that's with one machine that runs, let's say, neck to feet, because, the cord runs that whole area. So whether it's a shoulder or a hip or a knee or wherever, elbow, wherever these tendons are, treat inflammation in the periosteum, trauma to the periosteum, 94 and 783, 321, reboot, 20 pain reaction, that makes sense, with 783. Congestion, but this is something Dr. Musnick has found. And then scarring in the periosteum. So when you think of the periosteum getting inflamed and aggravated, inflammation leads to chronic inflammation, leads to scarring. So you're going to have scarring in those little teeny fibers that are on top of the periosteum. And in addition to what he's had, I'd consider running 91 and 783, just because I think of the calcium deposits on the periosteum sort of like ground glass. And then vitality in the periosteum, all for 2 to 3 minutes or however long it takes. And then torn and broken in the periosteum. When you have a tendon that's short and tight and dysfunctional, it pulls on the periosteum more than is mechanically reasonable. and creates little micro tears in the fibers, the well-innervated, pain-sensitive fibers that are in the periosteum. So he suggests that for as long as 45 minutes. So torn and broken in the periosteum and torn and broken in the tendon can run for as much as 45 minutes. Then fat sensitivity. Hadn't even thought about that. Fat can produce different biochemicals, some of which can be sensitizing or inflammatory. So palpate the region. If you know or suspect there is fat in the region and it's tender, treat the adipose. Who thought, right? Who knew? Inflammation, pain reaction or pressure, 321 reboot and 284 in the adipose. Places you're going to find an adipose pad, more likely to be in places like the elbow and the shoulder, and like the patellar tendon in the knee. So if you have a patellar tendonitis, remember that there's a big fat pad at the knee that should be treated. And I would add 3 because the adipose sclerosis. So once the fat gets inflamed, it's going to sclerose or scar down to the tendon, and it doesn't scar, it scleroses. So that fat sensitivity is going to be 3, not 13. Then remember that every time there's a tendon, there's a bursa. So residual pain near a tendon can be from bursa sensitization as well as the periosteum. Less commonly, bursas may be inflamed and filled with extra fluid. So look for bursal swelling at the anterior lateral acromion. So there's, 9 bursas in the shoulder, there's 13 in the knee, subpatellar tendon area, as well as the distal Achilles. There's Bursa, I'll show you pictures in a minute. There's a bursa at the distal Achilles between the Achilles and the calcaneus. You can palpate for sensitivity or swelling or warmth and then treat the bursa with the FSM. I find that even when the bursa is pain sensitive, it's not always swollen. It's just tender, and it's hard to distinguish the tendon from the bursa. So if you're going to treat inflammation of the bursa, 140 and 195, and then once again, he has 40 and 10 running on a separate machine. This is not something I've ever thought of when it comes to tendinopathies. I certainly didn't think of it when it came to me. So a second machine on 40 and 10 when you treat somebody that has chronic tendinosis. Inflammation of the bursa, trauma, chronic inflammation, pain reaction, 20, rebooting, 321, 20, 50, congestion, scarring in the bursa, 195. Don't forget 3, sclerosis in the adipose, 3 and 97. And there are times when the bursa can get little tears in it, 124 on A and 195 on B. So that's the bursa. And these are great pictures. So you look at the bursas that are in the shoulder. There's the subdeltoid bursa. There's the subscapularis, subacromial bursa, coracohumeral ligament, and bursa, subcoracoid bursa. There's 9 bursas in the shoulder. So anytime you're treating shoulder tendinopathies, and remember that there are times when the patient presents with multiple trigger points in the shoulder muscles. So it'll be infraspinatus, teres, major teres, minor, supraspinatus, subscap. All the muscles will have trigger points in them. And you treat the muscle, treat the nerve, 40 and 396, treat the muscle, and it doesn't work. At that point, use 124 and 77 and 124 and 191, torn and broken in the connective tissue and the tendons. So the connective tissue attachments for the teres, especially the 2 teres, infraspinatus, and even subscap, are all sort of flat kinds of tendons. They're not the round tendinous structure as we think of with the biceps. So when you've got trigger points all over in the shoulder, one of the things besides treating the nerve I've started to do in the last 2 years is torn or broken in the tendon, and all the trigger points just disappear. That's for partial thickness tears that we don't suspect. Elbow tendinopathies are, unless they're playing tennis or doing something pretty bizarre, it's a lot of workstation problems. He says get them off a laptop. Some of us don't have that option to get off a laptop, so you can put your laptop up on a stand and use a wireless keyboard and put your laptop up, so a wireless keyboard, wireless mouse, and that gets your neck out of flexion and tends to reduce the nerve inflammation that affects the elbow. Epicondylitis is just torn and broken in the tendon, torn and broken in the periosteum, inflammation in the tendon and periosteum. 124 and 191, as you remember, is one of those time-dependent frequencies, and can run for as much as 45 minutes. Add cord sensitization. This is not something I've been doing with my tendinopathy treatments, either on myself or on my patients. So this is a good reminder for everybody, and I'm really pleased that Dr. Musnick had such good success with this and presented it as a symposium case report. He's also found that cervical facets and ligamentous instability in the C-spine for the elbow pain, this is facets and discs in the C-spine. The C7 nerve root will cause lateral tendinopathy, medial tendinopathy, and the elbow is C6. And when you treat the elbow, you almost always run it from the elbow, from the neck to the elbow, and treat the neck as well as the elbow locally. Bursas in the hip, trochanteric bursa, glute medius bursa is in the front. Ischiogluteal bursa is along the ischial tuberosity. Look how long that is. So when patients say they have pain with sitting, there's a bursa there. Psoas bursa. So these are people that have anterior hip pain, trochanteric bursa. This ischiogluteal bursitis is a thing. Bursa and tendons in the knee. There's 13 bursas in the knee, and these are just a few of them. But every place there's a tendon, there is a bursa on one or both sides of it. So there are bursas at the hamstrings on both sides, at all of the lower leg muscles where the tendons attach, both to the femur and the tibia and the fibula. There's bursas everywhere. The bursa between the quadriceps and patella and over the patella. It's just a reminder, treat the tendon 191, the bursa 195, the periosteum 783, and remember in the knee there's a big fat pad 97. Achilles tendon, this is my issue because of 2 years spent on an antibiotic that kills the tenocyte. The retrocalcaneal bursa, there are bursas here. The tendon attaches or weaves into the calcaneus. This is a fat pad, so there's going to be sclerosis in the adipose. The thickening in the Achilles tendon is up here, and that is 284. Chronic inflammation, it's 13. It's neuronal sprouting. It's the blood supply, 62 and 162, and it's the bursa. Tendinosis is an abnormality. So you start with tendinitis, and that becomes, when it doesn't heal and it becomes chronic, the collagen becomes disorganized, and this is way more technical information that I have command of, but you can check with Dr. Musnick about this. So the tendinosis, the thickening, happens in the middle of the tendon, the connective tissue attachment to the gastroc and soleus, the triceps surae, and then down here at the Achilles. So that's the pathology. The proteoglycans and the glycoproteins changes. The collagen types change. And so the character of the tendon is different. So biochemical changes, there are changes in the matrix. What happens is the tenocyte, and this is from Dr. Cross's presentation 2 years ago. When you have tendinopathies or tendinosis, the tenocyte changes its signaling and begins to express the genes that create inflammatory cytokines. So you have increased expression of all of the inflammatory cytokines, substance P, glutamate, COX-2, and the cytokines and prostaglandin PGE2 goes up. Enzymes I don't know much about, but needless to say that chronic tendinosis or chronic tendinopathies, the chemistry and the genetics in the tendon are not normal. So the frequency still seems to work, 191, but what you have to do to it and your patience with it once it becomes chronic is a different story. So for treatment with FSM, of course, you treat with the concussion protocol if there was an injury, trauma in the tendon if there was an injury, inflammation in the tendon, even those are not a big inflammatory component, but 124 and 191 regenerates the degenerative tendon structure, but it takes 45 minutes, and I'm living proof that it's not a one-visit fix once it's chronic. So this is the start. The peripheral sensitization, the tissue damage starts it. Then there's peripheral nerve sensitization. There are mast cells. It's an immune system activating process. So mast cells, macrophages, TNF-alpha, interleukin-6, we know we can reduce those with 40, but bradykinin and serotonin receptors, calcium receptors, gene regulation, substance P, and it forms this what's the word I want? Vicious circle of perpetuation that creates the pain and inhibits normal tendon repair. Repeated activity in the class C pain fibers sensitizes the spinal tract neurons, this sub-threshold, like now he's using your hand, but sub-threshold inputs down in your Achilles reach a threshold and create sensitization, creating pain awareness kind of full time, and sensitizes the tracts in the spinal cord and the brain that represent those areas. So there are spinal sensitization in the spinal thalamic tracts, and the supraspinal areas that he's talking about are in the thalamus and the sensory cortex, and inevitably in the medulla where the pain tracts and the spinal-reticular tract and the neospinal thalamic tracts up in the medulla, then up through the thalamus and up in the sensory cortex. So there's cord and brain issues that suggests that you'd run not only 40 and 10, but possibly 40 and 89 in somebody like me where it's really chronic. We haven't done that yet. There's NMDA receptor and substance P mechanisms in both the spinal cord and locally. So 40 is your friend. Come on. There we go. What is that? It's weird. So FSM treatment for chronic tendinopathies or tendinosis appears to be the best modality, but you can forgive Dr. Musnick for being slightly prejudiced. 124 and 191 for 40 to 50 minutes. Do this once to twice a week for 3 to 4 sessions. So By the time you reach a tendinosis, it is not an easy fix. 40 and 396, which I hadn't even thought of last year. Inflammation in the tendon, running that by itself helps, but it doesn't get it done because the problem is that the tendon fibers are abnormal. Also suggests that you run trauma in the tendon, 321 in the tendon, congestion in the tendon to try and reduce the thickening. This slide doesn't have the blood vessels, so 40 and 20 was 62 and 162, the blood vessels in the capillaries, along with the nerves, torn and broken, and inflammation in the periosteum, inflammation and congestion in the bursa. So if you look at the anatomy pictures and think of the area both regionally and centrally, how it connects to the brain and the pain mechanisms, gives you an idea. Also treat any joint tissues associated with the tendon. So inflammation, hypermobility, if you're dealing with elbow and shoulder, you're going to have to deal with the neck. Dealing with the Achilles, as we found out, we had to treat my SI joint, tape that and treat the SI joint and the L5-S1 segment. So by the time it's chronic, there are upstream spinal joint issues that are related to it. One of the things that is true about tendinopathies is that eccentric strengthening produces better results. They actually produce the only results. So an eccentric exercise is an exercise that weights the muscle while it is lengthening. That is eccentric exercise. So probably the most studies have been done on eccentric exercise in the Achilles, but I think some of these British Journal of Sports Medicine articles are about other tendons. It's really well documented at this point. Eccentric exercise works better than PRP. That paper was presented at the sports medicine meeting I went to in 2011, I think, in London. And so eccentric exercise, if you're not familiar with it, figuring out how to weight a lengthening muscle is its own skill set. If you are not skilled with it, I suggest you find a physical therapist or a trainer who is, or you study up and figure it out before you start exercising a patient with it, because it's really easy to get confused. And concentric exercises make tendinopathies worse because it puts more strain on a torn tendon. If the tendon is lengthening for some reason, that doesn't happen. So I recommend these references to you, and you can Google eccentric exercise and tendinopathies and find everything you need to know. We do know that steroid injections are a really bad idea. Even though it's inflamed, even though it's thickened, steroids compromise tendon strength and structure and can actually cause the tendon to tear. NSAIDs don't work. Friction massage is some sort of third world torture when you have a tendinopathy. It is horrible, and it doesn't work. So that's another really good reason to not do it. Ignoring the spine if there is a facilitated segment. So if you've got C-spine issues in neck or elbow or wrist tendinopathies, or if you have lumbar spine or SI joint issues, it doesn't work to try and repair the tendon without addressing the spine. Ultrasound alone, which may be bad news for the physical therapists in the group who've been doing ultrasound on tendons for, what, 40 years, 30 years? Yeah, it doesn't work. So I recommend that you, if you're interested in tendinopathies or if they find their way into your clinic, I recommend that you look these up and confirm it for yourself. But otherwise, I'd take Dr. Mesnick's word for it. And then the other case I wanted to put up here was David Murphy's case report from the symposium in 2017. And he did restless leg and a head trauma case, both of which worked out really well. But this is a connective tissue disease case, and it is notable because it is genetic. It is incurable, okay? These people do not improve. They do not recover. Loeys-Dietz, I think I'm pronouncing that correctly, syndrome. It's an autosomal dominant connective tissue disorder. His patient got it from his father. It affects the collagen structure of the blood vessel walls. There is a significant predisposition to the formation of aneurysms and dissections of the large artery, especially the abdominal aorta and the carotid. So it is not a benign condition. The literature suggests that 50% of the patients will have a peripheral artery aneurysm as distinct from aortic root, which are not identified by routine echocardiology. So these patients die from aneurysms. At some point, they will require vascular surgery, follow-up, and they have angiograms pretty much every year looking for aneurysms. And it's the connective tissue structure of the arteries that goes bad, that doesn't work. So this patient presented with level 6 to 7 pain, and these were David's treatments. The patient was willing to give it 3 treatment trials to see if he could help. So they did vitality, increased secretions, and torn and broken in connective tissue, the blood supply, the fascia, the ligaments, and the cartilage, and and apparently the tendon. 77 didn't work, which is odd. You'd think that 77 would work because it's a connective tissue disease, but 191 worked well for this patient. So this is what he did. I'm wondering if maybe he did 40 also, but he did vitality, increased secretions, and torn and broken in the tendon, the blood supply, the fascia, the ligaments, and the cartilage. And 191 is what worked the best. 77 connective tissue did not work, which you just have to go with what works, I guess. So as the treatments progressed, the pain levels dropped. His spasticity and the muscle twitches began to decrease as the connective tissue repaired itself. Joint pain would flare up. He'd use just the extremity, muscle, ligament, tendon, Bursa on an AutoCare. I imagine it was week 1 to week 4. After the 3rd treatment, the patient said it was the fastest relief he'd ever gotten and better than any drug he had ever been prescribed. After the 5th treatment, the pain level dropped to a 4 and has consistently stayed there, with the exception of flare-ups. Remember, this is a genetic condition, and anything that challenges the joint, strains the tendon, or causes an increase in inflammation will cause the immune system to flare up. So the patient now describes the pain as a dull ache as opposed to the sharp, boring pain that it was before. So this is a great case. Now this was interesting. TTH, remember the kind of like the energetic influences that cause chronic pain? There was one protocol that flared the patient up. It is, when you look at TTH on the AutoCare or the custom care, it is probably 6 or 8 of the emotional frequencies plus the 7 combinations for the energetic influences, and flared him up. I still can't figure out why. So I have no idea. Can't tell you. We don't even have not even a wild guess. Chronic ligament instability was another one that made him worse. Don't understand that either. You have to go with experience, but gotta wonder why. The patient had memory problems, so they ran the chronic forebrain. No significant change. You might want to try brain fog. So the chronic forebrain is more for like kinds of dementia, and memory is very diffuse in the cortex. So you might try brain fog. You might also try treating the midbrain. So if a patient has chronic pain levels of a 7, he's going to have difficulty with short-term memory for sure, just because of the stress hormones in the brain. So I'd probably go with 40 and 89 to improve the memory and see if that helped, or brain fog. He had keloid scarring that resolved during the treatments, which had been present for 4 to 5 years, even though they never addressed scarring in the connective tissue. I don't understand that one either. What they were treating was inflammation and torn and broken in the blood vessels, the ligaments, the cartilage, and the tendon, and the keloids went away. I don't get that either, but it's nice that it did. Patient's comments: as an overall sense of confidence to keep going has come from treatments. This is the patient's own words. David has provided. These have enabled me to have a much better quality of life in comparison to what I had previously. I will never be cured, but certainly my life has been greatly improved from the use of FSM and osteopathy. So it's the combination of normalizing motion in the joints and treating the connective tissue. So you have to wonder if he's going to treat torn and broken in the ligaments, the arteries, if it would help with the reduce the possibility of the formation of aneurysms. I guess there's no way to know until you see how the patient does going forward. For me, this is an ongoing weekly need, just like people need to shop. I need to go for osteopathy. It's a necessity and not a luxury. I can notice when there are gaps in treatment, and I do start to head back towards my condition prior to FSM. So this patient would obviously be, if finances allow for it, this patient would be a good candidate for custom care. So I'm going to end up doing a webinar on just how to use the custom care to improve patient outcomes. But if finances allow it, this patient would be a good candidate for a custom care, so he could treat himself like he's going into David's once a week. But if David programmed onto a custom care what he's using once a week, the patient could treat himself every night, 3 times a week. And how much would that improve the patient's condition? It's just a thought. Symposium is going to be available on MP3s. We aren't even going to make CDs anymore. We're hoping we're going to be able to make it downloadable. Yes, Kevin is nodding, so this is good. I think we're going to have it on disk. We may end up putting it on a jump drive since so many computers don't even come with disk drives anymore. Jay Johnson from Tree Farm tells us that they will be available around the middle of May. By the time we get the graphics done, it's usually the 1st of June. So in there someplace we will have the MP3s, and those will include the PDFs of the slide presentations. So the Symposium and Advanced are sold separately. You can buy them as a combo, but they're available separately, so you can buy one and not the other, or both. And so the slides will be available, so you can listen to the audio and go through the slides. Our upcoming events in May, Kim Pittis has developed a just absolutely fabulous FSM Sports Seminar, FSM Athletic Applications. There is a specialized sports laminate that's different from your core laminate because it doesn't have all of the visceral stuff on it. And I think there's 6 practicums in 2 days, so it's a lot of hands-on. It's usually a fairly small group, like I would say 12. I think we limit it. There's a limit, no more than 20. She's going to be in Columbus, Ohio, May 20th and 21st, and probably in Phoenix in August, which is when we did it last year. That's always exciting at about 112 degrees, but you know, it dries out the sinuses, and they're in a great sports facility in Phoenix in August. So keep an eye on the website for those. Call the FSM office or sign up on the website for that. This is just a note for, that slide turned out weird. Just a reminder for the advanced students. The frequencies on channel A for mold are 23 and 95. 23 seems to work better, but both 23 and 95. Mold can affect the gut, the sinus, the vagus nerve, the brain, the liver, the nervous system, and the immune system. So sometimes your patients that have gastroparesis or liver disease or brain fog or depression or anxiety or whatever. What they really have is mold infection. Number of fibromyalgia patients, number of chronic fatigue patients, number of gastroparesis patients have ended up being almost all mold issues in the vagus. Dr. Neil Nathan's 3-hour workshop on mold in the advanced will be available on MP3. This is just the tip of the iceberg. I highly recommend that you look into that, especially if you seem to be attracting more and more chronic patients. The mold story is, so there's urine testing for mold metabolites, and it's a complicated picture, but it's certainly worthwhile. Special events for 2017. We're going to do a masterclass again in Portland. It's not an advanced. We recommend that you have taken the advanced before you come. It's usually a small group. We're in a relatively small meeting room. This year it's going to be September 9th and 10th. Last year I had it on my birthday on Labor Day weekend. So we had a very cozy group because it was Labor Day, and who wants to, go out of town on Labor Day for a seminar. So it'll be September 9th and 10th. There's only room in the schedule for one of them this year. Next year we're going to try and get 2 of them because they're really fun. It's a lecture and practicum combination. We treat each other, we treat volunteer patients. I usually have local patients come in, and we look at their, we do the diagnosis and the treatment. Usually we treat the patient for an hour to an hour and a half. Last year we had a myelopathy patient who didn't know she was a myelopathy patient, and we had an abdominal adhesia patient from endometriosis. The reviews for this class were extraordinary. They were just wonderful, and it was a great small group experience. I don't remember how much we charged for it. We will probably be back at McMenamins, but in a smaller room. McMenamins at Kennedy School is just a lovely venue, and I like that. That setting. It's fun. They have great restaurants. So we'll probably be at McMenamins September 9th and 10th. Join us if you have a chance. And this is just how we always close, changing medicine one patient at a time. That ends up being what we do. It's what you're doing every day that you practice, every patient that you help. So every one of you that's here, every one of you that hears this webinar, every one of you that uses FSM in your practice, you change patients' lives in ways that you're certainly aware of, but we come to take it for granted because we do it so often. I think you'll find when you read the resonance effect, you become more acutely aware of exactly what you're doing to change patients' lives, because the whole book is kind of a sequence of case reports that are sort of flow together in a fun narrative. But yeah, you guys are changing lives in ways you possibly don't appreciate. And there's just the idea that changing even one life can change the world. Think of the patients that you have gotten out of pain. Think of the 40 and 10 patients. Think of the fracture patients. Think of the IBS and the asthma patients. Think of David Murphy's connective tissue patient. Think of David Musnick's tendinopathy patients. When you change that life and get that patient out of pain, what happens? What happens to that patient's world? What happens to the family that he lives with and the people that he works with, and how he or she interacts with a grocery store clerk or a spouse or a child? Yeah, I guess that's a good way to close our meeting today. Stay in touch, check the website. I hope that you all get a copy of the resonance effect and pass it on to your patients. And we'll see you next month. Now what? No. There we go. Where am I going? Well, at some point, I'm going to figure out a way to turn this